Hi, ladies and gentlemen. I'm M.Malbrain from Brussels, Belgium, and this is part 2 of everything you need to know about fluid therapy. A brief story on the 7Ds, 4 phases, 4 questions, and much more. My lecture is on breaking bad habits, especially breaking bad fluid habits in critically ill patients. I told you in the first part that fluids are not innocent. The fact that fluids can be given in any patient is virtual reality. So I took you into the matrix, and you took the red pill. And we need to understand that fluids are not innocent bag of water, but drugs, and should be treated accordingly. So this is part 2. And I explained you on the 7 Ds of fluid therapy. D1, definitions. D2, diagnosis. D3, drug. D4, dose. So now we will continue the lecture with D5 on duration, D6, de-escalation, D7, discharge. D1 multiplied with D2 to D7 gives us D to the 7th power. And this is fluid stewardship. So every patient in our ICU deserves a personalized treatment. Also when it comes to fluid management. So D1 was on the definitions, especially fluid accumulation, fluid overload. What is hypervolemia, hypovolemia? How can we diagnose this? D2, diagnosis. So are all septic patients hypovolemic? We can have monitoring tools for diagnosing hypovolemia. It could be clinical, laboratory findings, radiological findings. I told a bit of bioelectrical impedance analysis, and body composition with the 4 major compartments. So it could be fat, water, protein, and minerals. And when you look at the 4 compartments of the water, this could be intracellular, intravascular, interstitial, or transcellular fluids. Some also talk about the 4 spaces. This could be the first space intravascular, the second interstitial, and the third space, if it exists, it's fluid in the pleural or peritoneal cavity, and the 4th space could be again transcellular or lymphatics. D3 was all about drugs. Fluids should be treated as any other drug, in analogy to antibiotics, with indications, contraindications, and adverse effects. We should ask ourselves the 4 questions. So when to start fluids, when to stop fluids, when to start fluid removal and stop fluid removal. So it's all about the benefits of fluids and the risks of fluids. Told you about the 4 indications. So it's resuscitation, maintenance, replacement, and don't forget nutrition. So drugs do have adverse effects. So the treatment should be appropriate, maybe combination therapy. Timing is also important. 4 Ds of fluid therapy. It's drug. I told you about the dose, the pharmacokinetics. So this is how the fluid interacts in the patient. So what becomes of the fluid, and the pharmacodynamics is how the fluid acts on the indication was given for, like shock or sepsis, and toxicity. So this was part 1. So now we move on with part 2, starting with D5, and this is about duration of fluid therapy. Because what I really want to know at the bedside is, when do I start giving fluids and when do I stop giving fluids? So the benefits of fluid administration versus the risks. And for that, you need to see more than others and more than traditional filling pressures. When we again compare or look at the analogy between antibiotics and fluids, when it comes to appropriate duration, we know for antibiotics there is no strong evidence, but there is a trend towards shorter duration. And we don't use antibiotics to treat fever or CRP or infiltrates, but to treat infections. And looking at antibiotics, so we must have the courage to stop them when they are no longer needed. And in the literature for different indications, we go for shorter durations. And even in Africa for meningitis, you get 1 shot of antibiotics and that's it. So likewise for fluids, there is no strong evidence, but a trend towards shorter duration. And we should not use fluids to treat the numbers like a low CVP, blood pressure or urine output, but to treat shock. When we look at the treatment to response, we stop the antibiotics when there is no active infection. Maybe there is a role for biomarkers, and the same could be true. We stop fluids when shock is resolved, and maybe there may be a role for other biomarkers to look at end-organ failure and dysfunction. So D6 is on de-escalation or coming down with the amount of fluids when the situation of the patient has improved. So the third question is, when do I start fluid removal? And the fourth question, when do I stop fluid removal? So the benefits and the risks of fluid removal. Again, for that, you need to see more. The escalation of antibiotics may not help individual patients. We believe that it could benefit the ICU as a whole. Although only 39% of our colleagues do de-escalate, we must have the balls to change a winning team. So again, comparing antibiotics with fluids. For fluids, it's probably important after the initial early adequate fluid management, we need to stop ongoing fluid resuscitation and aim for late conservative fluid management. So 2 consecutive negative daily fluid balances within the first week. And in some patients, we need active fluid removal, late goal-directed fluid removal or de-resuscitation. So I think it was in 2014, 2 papers were published on the dynamic phases of fluid therapy, the 4 phases. Although the acronym was different to illustrate these 4 phases, and if you would ask social media and Twitter, there is a clear preference to use the acronym ROSE instead of SOSD. So what is the ROSE conceptual model? So after resuscitation of the patient, we optimize and stabilize organ function. We stabilize the patient, de-escalation, and then, if needed, de-resuscitation or active fluid removal, evacuation. So hence the ROSE acronym. So within the first minutes and hours of shock, fluid balance should be positive. After the first hit, whether it being trauma, sepsis, burns, pancreatitis, fluids must be given, saves lives, and fluid balance should be positive. Then comes the second hit, which is related to ischemia reperfusion, and it's all about organ support and maintenance of homeostasis and stabilization. So this is to support and save the organs. And the third hit refers to a global increased permeability syndrome. Normally the patient enters the flow phase spontaneously, like in polyuric phase after tubular necrosis, but some patients may need active fluid removal. So this is evacuation or de-resuscitation. The fourth hit may come from hypoperfusion if fluids are removed too aggressively. So hence the ROSE acronym. Just have to point out that the rose at the end is just a dry rose. It's not a dead patient. And I'm very happy to see that this conceptual model has been taken over by other colleagues, like for instance, in neurocritical care. It's very complicated to guide us through the different phases of fluid therapy because there is no one single study looking at all these different phases. So some of the big fluid trials looked at the very early phase, like the Rivers trial, and then most of the big trials comparing balanced and unbalanced fluids or crystalloids and colloids, they were randomized patients only after 24 hours and with an amount of fluids given before randomization being as high as the fluids, the study fluids giving afterwards. So it's difficult to draw any conclusions from that. But if we're going to rescue our patient with goal-directed therapy, at some point we need to optimize the organs and aim for late conservative fluid management to stabilize organ function. And in some patients, late goal-directed fluid removal is needed to evacuate the excessive fluids and save the patient. While in the initial phases of resuscitation, we will guide our treatment and fluid therapy based on fluid responsiveness, volumetric preload parameters. And when these normalize, we may stop ongoing fluid resuscitation. And when there is an impact of fluid overload and fluid accumulation on end organ function, we may de-resuscitate and we stop it when there are signs of hypoperfusion, maybe with indocyanine green plasma disappearance rate dropping or mixed venous saturation. But there are a lot of questions on how to guide the patient through these different phases. The ultimate goal is to avoid global increased permeability syndrome. So why is that? Well, you could ask yourself whether peripheral edema anasarca is just cosmetic. I believe it's not cosmetic, but it is bad medicine. Why is it bad medicine? Because a positive fluid balance is an independent predictor for poor outcome in patients with sepsis. And if you look at this data, you can see that restrictive regimen carries a better prognosis than liberal fluid management. Why is that? Because fluid overload at the outside mirrors fluid overload at the inside. And all the organs will be swollen. There will be venous congestion, so there will be forward and backward failure, and this will lead to multiple system organ failure and dysfunction and a global increased permeability syndrome, leading to further inflammation and hyperpermeability and fluid accumulation. So late conservative fluid therapy may be the way to go. And if you compare different studies looking at it, you can see that early conservative and late conservative fluid therapy carries better prognosis than if you give liberal fluids all the way along the course of the disease. So when should you think about de-resuscitation? When the patient is not transgressing spontaneously from the ebb to the flow phase of shock and stays in a persistent state of global increased permeability syndrome, which is a positive cumulative fluid balance that persists plus new onset organ failure and dysfunction. And this could be fluid overload in the lungs, like low PF ratio, an increased lung water and pulmonary vascular permeability index, or an increased intra-abdominal pressure, one of my favorites. So how then to assess hypervolemia? Or said otherwise, how to guide de-resuscitation? Well, there are some clinical assessment of fluid overload, which could be reflected by an increase in body weight, fluid balance or cumulative fluid balance, second, third space fluid accumulation, peripheral edema, or biochemical assessment of fluid overload, like you would have hemodilution, dilutional anemia, low protein values, low osmolality, maybe ongoing infection, inflammation, poor source control, increased capillary leak in the very interesting serum albumin, CRP divided by the serum albumin. Radiological assessment with X-ray or ultrasound, cardiac ultrasound, Hemodynamic assessment, I think the absence of fluid responsiveness is important. A negative passive leg raising test. If volumetric preload indicators are increased, and then the impact of fluid overload on end organ function, and I think increases in lung water, very important, or increased in intra-abdominal pressure. I think for the future, there may be some bright ideas on some monitoring for fluid overload. And this could be done with bioelectrical impedance analysis, total body water, and the ratio between extracellular and intracellular water, or calculation of total circulating blood volume with, for instance, the Dexter device, blood volume analyzer, and maybe electrical impedance tomography could be interesting. So D7. When you've treated well your patient and guided him through the dynamic phases, taking into account the 4 indications, 4 questions, 4 phases and the Rose model, at some point, hopefully your patient will be discharged. And I think it's important to gather and collect some data afterwards. You could ask yourself the question, is there a problem with fluids? What should you be doing? What do the guidelines tell? What happened in Northampton, M5 in Scotland, Brussels, and can you demonstrate an impact? So there is definitely a problem. You should aim for fluid stewardship. Guidelines are not personalized, and you can demonstrate an impact with some key performance indicators. So what happened this is obviously Northampton. A good friend, Johnny Wilkinson, he looked at IV fluid prescription there, and he found that some patients were dehydrated or fluid overloaded, and patients were on CVVH for either overload or underload. And the test on the knowledge of IV fluids by doctors was poor. Correct answers on average for different questions were around 8 to 40%. So also the knowledge on the composition of the fluids that were available in the hospital was poor, again, results of 0 to 40%. So in Northampton, they were sacked. You could say just fake news, doesn't happen in my ICUs, just in Northampton. But they took for action, started a 3-pronged attack on IV fluid safety with education, changing practice, and increasing the awareness. And they performed a clinical audit in twice 60 cases, medical cases. They found out that the sodium needs were exceeded 9 times too much. The potassium needs per day, they were not reached, so they didn't reach 1 millimole per kilo per day. And looking at the surgical files, sodium again was given too much, 4 times too much, and potassium needs were not covered, reaching only 32%. Looking at the prescribed fluids, internists mainly prescribed saline, surgeons Hartmann solution. So saline in 64% as maintenance. Remember, there is no glucose in saline, and surgeons prescribed Hartmann solution. Inappropriate fluid prescription was present in 32% of medical cases and 10% of surgical cases, and this was defined as a high sodium, above 145, and given more sodium, like saline, or low and decreasing sodium, less than 135, and prescribing hypotonic solutions like glucose. And for potassium, the same, a high potassium given more potassium or low potassium, and there the cutoffs were 3.5 and 5. Was there lab testing? So for antibiotics, if you want to prescribe aminoglycosides of vancomycin, you want to know kidney function. But we do prescribe fluids without knowing kidney function and urean electrolytes. And this was the case in 48%, having results on the same day, and in surgical cases, only 37%. So I think the clock is ticking, and we're not doing a good job. I think we can do better. Yes, we can. And maybe it's time for fluid stewardship. in analogy to antibiotic stewardship. You can read all about this in open access paper published in Annals of Intensive Care. And this paper received a lot of attention on social media with a very high altmetric score. So definition of fluid stewardship is a series of coordinated intervention introduced to select the optimal fluid dose and duration of therapy that results in the best clinical outcome, prevention of adverse events, and cost reduction for the patient and for the hospital. So what happened this is the Atomium in Brussels. We performed a snapshot of fluid consumption, a survey of doctors and nurses, and then a medical audit. So if we look at the consumption of infusion therapy, you see that the largest amounts of fluids given was saline and then balanced crystalloid plasma-lite. We performed a knowledge survey for doctors and nurses, and the average score was 40%. So not very good. Just showing some answers to some questions. Here 75% got it right, so the glucose content of plasma-lite is 0. Plasma-lite cannot be given as a maintenance solution. The sodium content of saline is 154. About half of the respondents got it right. What is the sodium content of glucion, which is ready from the shelf? So it's 54, 40% got it right. And then when asked, do you take into account fluids that are administered for drugs and antibiotics, 40% did. And what is a good fluid bolus? So it's about 4 ml per kilo, only 25% got it right. So the average scores for doctors were 32%, and for nurses performed a little bit better. We changed the questions a little bit, was 50%. So in Brussels, we are sacked. And I guess that if you would do the survey in your hospital, you would be sacked as well. So we could all say this is fake news, or you can make a difference. Because it's important to set our targets right in order to reach our goal. And the goal here is appropriate fluid management, like you would do with any other drug. And this we did with on the floor learning, following the 5 Ps: physician, prescription, pharmacy preparation, and then back to the patient. So for fluid stewardship, you need doctors and nurses. These are your stewards, your ambassadors. You need to teach them. You need to increase the awareness with flyers, poster, screensavers, and then you need to provide feedback. Plan, do, check, act, cycle. So meanwhile, what happened in Fife in Scotland, Marshall McDougall's hospital. So they checked that some process measures or the right fluids being described in the right amount, is fluid balance available in the chart, are the guidelines followed, and so forth. So when they implemented the fluid charge, they saw that the average amount of fluids given per kilo per 24 hours increased, and this is the maintenance rate at about 25 ml per kilo per day. So should be okay. And then when they started to work on fluid, presentation to the staff, then they moved to a new hospital, there was an increase in fluids, the guidelines were introduced, a decrease in fluids, fluid nurse charts. So you see a decrease in saline, and then you see an increase in balanced crystalloids and hypotonic maintenance solutions here over the years. And if they look at the consumption of fluid in liters per occupied bed, so it was around 0.64 and it dropped to 0.34, resulting in savings of a vast amount. So meanwhile, back to Brussels, how did it end there with the consumption of the infusion therapy? You can see that there was a drop in saline and little increase in plasma light. We also saw drop in the ugly, sort of speak, maintenance solutions, and an increase in ready from the shelf hypotonic maintenance solutions. But overall maintenance solutions decreased. So what are the key performance indicators? We want to give more balanced and less abnormal saline. So you see an increase in this ratio. We also want to give more correct hypotonic maintenance solutions versus the unbalanced maintenance solutions. So there is an increase here. And if we then follow up until the last 2 years, you see that the usage of fluids in liters per stay dropped from 3.8 to 2.3. So it's minus 1.5 liters per stay. And if we look at the fluid consumption in liters per day, is the same drop as Marshall McDougall observed from 0.6 to 0.4. So it's minus 0.22 liters per day, or minus 33%. So ladies and gentlemen, to wrap things up, I hope I convinced you that the way we look at fluids now is a virtual reality, and that fluids are not innocent bags of water, but fluids, medical fluids, should be treated as drugs, the same way we treat antibiotics. So to summarize my talk on personalized, individualized fluid therapy, we talked about D1 definitions: fluid overload, fluid accumulation, hypervolemia, edema. D2 was diagnosis. So how are you going to diagnose hypovolemia? With some monitoring, clinical, laboratory, radiological, organ function monitoring. And I told you about BM body composition. Remember the 4 compartments: fat, water, protein, minerals. And when it comes to water, it's intracellular, intravascular, interstitial, and transcellular. If we refer to the 4 spaces, first space is intravascular, then interstitial, then the 3rd space, pleural, peritoneal, and the 4th space being transcellular lymphatics. D3 is all about drug, indications, contraindications. We have to ask ourselves 4 questions: when to start IV fluids, when to stop, when to start fluid removal, and when to stop fluid removal. Only 4 indications: resuscitation, maintenance, replacement, and don't forget nutrition. Remember that only 6% is for resuscitation, 25 maintenance, 33 replacement, 33 nutrition. So 33 replacement being fluid creep for administration of drugs. Adverse effects, analogy with antibiotics, appropriate therapy, inappropriate therapy, combination therapy, and timing. So the 4D concept, drug, and then comes the dose with pharmacokinetics, which is the what becomes of the drug when it's administered, and the pharmacodynamics is the effect of the drug on the patient, so on the bug, if you would compare it to antibiotics, but here it's on the shock state, and toxicity when given too much fluid overload. D5 is duration, so stop fluids when they're no longer needed, when shock is resolved, when the patient has an oral intake. So duration should be appropriate, and we treat to response. D6 is on de-escalation. I showed you the Rose model with the 4 phases: resuscitation, optimization, stabilization, evacuation. Told a little bit on the monitoring, or when to guide de-resuscitation based on clinical signs, laboratory signs, organ function, radiological signs of fluid overload. Didn't mention the 4 hits. I talked a little bit about it during the Rose, with the first hit, insult, ischemia, reperfusion, global increased permeability syndrome, and of course, 4th hit by avoiding hypovolemia. D7 is on discharge, so the data you can collect on fluids in your ICU, in your hospital. And this is what we refer to as fluid stewardship. You should perform a snapshot of your consumption, do a survey on the knowledge. Doctors and nurses perform a medical audit, maybe surgical patients, medical patients, check for the appropriateness, then define key performance indicators. So more balanced, less saline, more hypertonic balanced maintenance solutions, less ugly maintenance solutions, and then implement the plan, do, check, act, cycle. So this, ladies and gentlemen, is personalized fluid therapy. And for implementing this, you need a fluid team, your fluid stewards, your ambassadors, doctors, and nurses. So I think there's no time to lose. Start fluid stewardship in your ICU, in your hospital. I hope you enjoy the first virtual International Fluid Academy Days. Stay tuned and thank you for your attention.